Hello, and welcome to the University Transplant Center's Kidney Transplant Patient Education class. The goal of today's presentation is to provide patients and their families with information regarding the evaluation process and the actual transplant process for kidney transplantation. We'll start our discussion by identifying the location and the function of the kidneys. The kidneys are located on either side of the spine near your waistline. They're about the size of your fist and are shaped like beans. So, with that said, if you were to ball up both of your fists, put them behind your back on your waistline, that is the actual location and approximate size of the normal kidneys. The function of the kidneys. The kidneys help to remove waste products from the body. It helps to clean your blood. They help to control the fluid in the body by balancing the salts and waters. The kidneys help to make strong bones and red blood cells, and they help to control the amount of potassium, calcium, magnesium, and phosphorus in the blood. These are all important elements in maintaining normal body function. The signs of kidney disease. As I stated with this assisting the body in maintaining fluid, when the kidneys are not functioning properly, you can have fluid retention. This extra fluid can cause shortness of breath. You can have mental confusion, abnormal blood or urine test results, headaches, high blood pressure, and fatigue. Some of the most common causes of kidney failure are diabetes. A great many people in the United States are diabetic and don't even know it, and have developed complications of their diabetes which can cause kidney failure. High blood pressure is another common cause of kidney disease. Chronic inflammation in the kidneys. This inflammation can be caused by either trauma, such as an automobile accident, or an individual who's kickboxed most of their life, who's taken several blows to the lower back. This can cause this chronic inflammation that can cause the kidneys to fail. Polycystic kidney disease. This is an autoimmune process in which the body develops cysts. These cysts develop in the kidneys and actually replace the tissue in the kidneys, causing them to fail. Polycystic kidney disease is hereditary, and if the patient has been diagnosed with polycystic kidney disease, family members should also be tested. Another common cause of kidney failure is scarring from infection during childhood. Sometimes children are born and the kidneys are not necessarily, or the structures of the kidneys are not exactly the way that they should have been. And this can cause problems where the children develop chronic infections. These chronic infections can cause the kidneys to fail. Chronic obstruction or blockage of the flow of urine, such as kidney stones, can also cause kidney failure. So now that we know that there are things that cause the kidneys to fail, what does this mean? Why do people need kidney transplants? Well, some of the diseases can cause damage to the kidneys. This damage to the kidneys can affect their function. And if the damage is severe enough, you may have kidney failure that results or requires dialysis. There are treatment options for kidney failure. As I just mentioned, one of those is dialysis. There are two basic types of dialysis. There's hemodialysis, in which a patient is hooked up to a machine with the use of a catheter or a graft, and the blood in the body is filtered of these toxins. This is usually done about 3 days a week for about 4 hours each visit. The second type of dialysis is peritoneal dialysis. This is a process in which a catheter is placed in the lower abdomen of the patient. A solution is then dwelled into the abdominal cavity. This solution is such that it causes those toxins to pull from the bloodstream and into this solution. That solution is then drained, thereby removing those toxins. And this is done in a cyclic or a cycle type process. Peritoneal dialysis does require a great deal of more strict regimen on the part of the patient. It's done at home, it's usually done nightly, and it requires a very, very clean and very regimented environment. Another option for kidney failure is transplantation. There are several types of transplant. Most commonly in the United States today are deceased donor transplants. There are also expanded criteria donors, deceased cardiac donors, hepatitis C positive donors for those recipients who are hepatitis C positive as well, and high-risk donors. It is important to note that transplantation is a treatment option that will not necessarily cure the underlying cause of kidney disease. For example, the diabetic. You may have developed kidney failure because of problems or complications of your diabetes. A kidney transplant resolves the kidney failure, but does not resolve the diabetes itself. Treatment options. We just touched upon expanded donor criteria. The average donor for a deceased donation of a kidney is usually a healthy individual with no medical history or problems such as diabetes, heart disease, high blood pressure. Now, there are expanded criteria donors. These donors are generally over the age of 60 or between the age of 50 and 60 years of age with two of the following criteria. Either the patient died of a brain injury or a stroke. The donor has a history of high blood pressure that has not affected the kidneys, that is known as benign hypertension. Or the donor has a serum creatinine of 1.5 or greater at the time of death. Normally, the serum creatinine of an individual with functioning kidneys is less than 1.0. But because of circumstances at the time of the individual's death, there may be a reason that the creatinine spikes and elevates greater than 1.5 and then starts to come down. These are still considered viable kidneys. A second type of expanded donation is donation after cardiac death. The donor that does not die of brain death criteria. The donor's heart must have ceased functioning within a preset period of time after discontinuing life support measures. For example, an individual has been perfectly healthy and had no other medical history, and for some reason suffers a massive heart attack. The patient is resuscitated, brought into a hospital. The brain is still functioning, the organs are still functioning with the assistance of life support. If the life support is discontinued, the heart fails, and therefore the patient will die. These are the organs that are donated as a result of cardiac death. A DCD, or donation after cardiac death kidney, can function just as well and as long as those donors age 60 or below. Another treatment option for kidney transplantation is that of living donation, or a kidney from a living donor. A living donor can be related, unrelated, or altruistic. To explain what an altruistic donor is, that is an individual who, for no other reason than wanting to provide life and health to another individual, donates one of their kidneys. They don't expect anything in return. They don't need to know who the recipient is. They just want to better the life of another individual. You may think that this rarely happens, but it does happen, and these donors are out there. Another option for living donation is paired donor exchange. Paired donor exchange is a process by which an individual has a living donor that does not match them, but that donor matches someone else. That other individual's donor, in turn, matches them. So the process is a swapping of donors, thereby allowing an individual who might not have had a matched donor to receive a kidney transplant, as well as another individual with an unmatched donor. The benefits of transplantation. Transplants increase the life expectancy of the kidney patient in comparison to dialysis. This transplantation actually enhances the quality of life through improved health and energy. Patients regain their sense of independence because they're no longer tied down to dialysis 4 hours a day, 3 days a week. And believe it or not, it is the least expensive treatment option for end-stage renal disease in comparison to long-term dialysis. So, what are the criteria for transplant? These are patients that must be on dialysis for end-stage renal disease or carry a diagnosis of chronic renal failure with an estimated glomerular filtrate rate of less than 20 millimeters per minute. It is important that patients, especially those patients on dialysis, know what their glomerular filtrate rate is. Patients considered for living donor transplant do not need to be on dialysis, but must meet the above criteria of a GFR of less than 20. Patients must be medically compliant and capable of following a complex post-operative regime. Basically, that means if a patient is not compliant with their dialysis, not compliant with their follow-up with their physicians, now, the expectations may be that they're not going to be compliant with their regime once transplanted. So it's important that we know up front that these patients are doing exactly what they need to be doing. Patients must have a body mass index of less than 40. The body mass index is calculated based on an individual's height and weight. Patients must have Medicare, Medicaid, or private insurance coverage. The reason being the average cost of an uncomplicated transplant is approximately $250,000. We need to make sure that you have financial support to help you through the process. The medications post-transplant, if had to be paid for out of your pocket, run approximately $1,500 a month at the onset of transplant. Therefore, it is imperative that patients have insurance that helps to cover some of those costs. Indications that the patient is not eligible for transplant, the contraindications. If you have an ongoing diagnosis of cancer or sepsis, we cannot transplant you. Part of that reason being is the treatments for sepsis include long-term antibiotics. The treatments regarding transplant require the patient to be on immunosuppression, which can and does lower the body's immune system. If you have an active infection, then we just increase the incidence or the potential for that infection spreading. The same goes for cancer. Advanced age alone is not a contraindication for transplant, but it is a relative contraindication in combination with other comorbidities. For example, if you are a healthy 70-year-old that plays golf or runs, has no other problems other than your kidney disease, there's the potential that you are eligible for transplant. However, if you are a 65-year-old diabetic with uncontrolled diabetes, seizure disorder, blindness, small vessel disease, cardiac problems, arthritis, and a multitude of other health issues, those are considered along with your age to determine whether you are or are not a candidate for transplant. Multiple unresolved medical problems, as I just mentioned, to include cardiac ejection fraction of less than 20%. A diffused irreversible small vessel disease. It's important to understand that the placement of the newly transplanted kidney is in the lower abdomen on the front of the body. And it's important that we have a good blood supply to that new kidney to maintain the life of that kidney. If you have small vessel disease, you do not have a good blood supply to that lower part of the body, and therefore there's the potential for that kidney dying. Another problem is end-stage cardiomyopathy. That is death of the heart muscle. If there is unresolvable death of the heart muscle, we cannot transplant you. Insufficient social support systems. Basically, it is imperative that a patient going through transplant has a warm bed to sleep in, a roof over their head, food, transportation, the ability to go to and from their doctor's appointments, be able to maintain and obtain their medications, and someone there to assist them through the process. Without these social support systems, a patient cannot successfully be transplanted. Recalcitrant noncompliance. This is noncompliance on the part of the patient where they continue to do the same things again and again and again, and rather than improving their condition, create more problems for themselves. Morbid obesity. That is an individual defined as having a body mass index of greater than 40. Ongoing illicit substance abuse. to include alcohol and drugs. Human immunodeficiency virus, HIV. HIV-positive patients are not transplantable at our program. However, there are other programs in the country that do transplant HIV patients. Dementia. Dementia is the process by which an individual loses their ability to maintain the identity of either who they are, where they are, what they've done in the past 24 to 48 hours, who others around them are, and such circumstances. If an individual has dementia, we cannot obtain informed consent to perform transplant. The pre-transplant evaluation. What does that include? Well, that includes a physical examination and complete medical and surgical history by our nephrologist and our surgeon. It includes cardiac testing, an echocardiogram or an ECG, an electrocardiogram, stress test. It also includes a chest X-ray. For those individuals over the age of 40 or under the age of 40 with a family history of colon cancer, it includes a colonoscopy. It includes a psychosocial evaluation, which again addresses the social support systems of the patient. It includes a dental evaluation to determine that the patient is free of infection in the mouth, a nutritional evaluation, and a number of blood tests to include blood count, blood type, chemistries, viral studies, the panel reactive antibody, or a PRA, which is our way of measuring the immune system's activity within the body and in the tissue typing. There are other tests that are specific to males and females that must be performed on an annual basis by the patient. These are part of their annual cancer screening. That includes for females a mammogram, which is an X-ray that detects the signs of breast cancer for women over the age of 40 or those women under the age of 40 with a history of breast cancer in the family. A pap smear. Cells from the woman's cervix are analyzed for signs of cancer. For men, it is a prostate-specific antigen. This is a blood test to check for prostate cancer in men over the age of 40. These tests, as I initially indicated, must be performed on a yearly basis in order to maintain your evaluative status and status on the transplant list. The transplant team consists of our surgeons, nephrologists, our coordinators, the transplant clinic discharge nurses, the social workers, our dietitians, financial coordinators, pharmacists, your primary care physician and or your nephrologist, your family, your friends, and most importantly, you. We like to provide information to our patients on our staff, the hierarchy of our staff. It's important that you just note that for our transplant center, Dr. Charles Nolan is our medical director. Dr. Greg Abrahamian is our surgical director. We have Dr. Robert Esterl as one of our transplant surgeons. Dr. Daniel Riley is also one of our transplant nephrologists. And Dr. Luis Velez is another transplant nephrologist. Our director is Ms. Jennifer Milton. Placement on the kidney transplant list. When your pre-transplant evaluation is complete and the results are received, those are results of all the tests that we just talked about, the selection committee meets to determine if you are ready to be placed on the list. Your coordinator is the individual that presents you to this committee and presents the findings of those evaluative tests that you've had performed. This coordinator will contact you by telephone and or correspondence to inform you that you have been placed on the list. You will receive a congratulatory letter that says, "Congratulations, you have been placed on the UNOS transplant list." It is your option to be listed at more than one facility. Here in San Antonio, there are more than one program, and so if you list in more than one program in the same city, you are still competing for the same organs. However, the state of Texas is broken out into 5 different regions. You have the option of listing in each of those regions, depending upon the actual requirements of each program you choose to list with. Patients have the option to refuse transplant at any time. It's important that you know that, because if for some reason you go through the evaluation process and you reconsider, you still have the option of being removed from the list at any point or time. Waiting for a transplant. The waiting list is a national computerized network. This list is managed by the United Network for Organ Sharing, called UNOS. UNOS is supervised by the federal government, who helps to ensure that patients receive healthy organs as they become available in the most fair and appropriate manner. As you'll notice at the bottom of the slide, there is a toll-free number that patients can call. That number is 1-888-894-6361, and you can contact UNOS at any point or time to obtain information regarding your list status. Factors that determine who will receive the available kidneys. Basically, there are 4 factors that determine who receives the available kidney. The first one being blood type. The second one being tissue type. The third being cross-match. Cross-match basically defines what antigens or antibodies you have developed in comparison to that of the donor kidney. And wait time. For kidney transplantation, the wait time is basically the first on the list, the first to be served with the available matched kidney. So looking at blood type, what blood groups are compatible? Now, for living donation, it is important that you understand that the compatibilities are taken into effect. For a patient with blood type A, you can receive a kidney from an individual that is also a blood type A or O. For blood type B, B or O. Blood type O will receive only an O donor kidney. Blood type AB can receive an A, a B, an AB, or an O. Living donors have to be compatible. Now, for deceased donor kidneys, those donations from the UNOS list, it must be a 1-to-1 match, meaning if you are a blood type A, you will only be offered a type A kidney. A B kidney, an O. AB will be AB. The reason for this is there are so many patients on the list that if we were to take all compatibilities into account, those on the O list might never receive kidneys. Wait times. This is one of the most difficult factors and most important factors for patients to understand. The average wait time for a patient with blood type O is approximately 4 to 6 years. Blood types A are 3 to 4 years wait time. B, 4 to 6 years, and AB, 2 to 4 years. Now, the one thing that's important for you to know, though, is mandatory national sharing for zero mismatch can happen at any time. What that means is if an individual donates a kidney and you are an exact match for that kidney, and you are the only exact match for that kidney, it doesn't matter where you are on the list. That is your kidney. The offer will be made to you first. While you're on the waiting list, so I'm on the waiting list, what do I do now? It is important that you attend all pre-transplant scheduled classes, which, of course, first of all, you're all here, so pat yourself on the back. You've just met your first requirement. You need to try and stay as healthy as you can. Keep in touch with the transplant team. Make sure that you are having your yearly updates. Notify the transplant team of any telephone, address, or insurance changes. You need your bi-monthly blood samples. Once you've been placed on a list, and if you are on dialysis, your dialysis unit will draw a PRA twice a month, and that is sent to us so that we have the most current blood sample on you when it comes time to compare your blood and tissue type to that of a potential donor. Contact the transplant team if you're going out of town. That's very important. Contact the transplant team if you've had a blood transfusion or if you've been hospitalized, because this can change the antibodies in the body, and we need to get a current sample to compare your blood type, tissue type, cross-match to that of a potentially donated kidney. Please remember that if we cannot find you when a kidney becomes available for you, we will call the next available match for the donor kidney. That is vitally important. If we can't find you, we can't transplant you. And we have a time frame in which we can contact patients. So if we've contacted you and told you we have a kidney available, it's imperative that you follow our instructions to the letter and that you come to the hospital when asked to. Further instructions while you are waiting on the list. Please notify your transplant coordinator as soon as possible if anyone offers to donate a kidney to you. The living donor coordinator will test any potential living donors to determine who would be an appropriate donor for you. A kidney donor can be related, unrelated, but must be healthy. Paired donor exchange is another option if your donor is not a match for you. The kidney transplant surgery. You will be under general anesthesia during the actual surgery. The surgery is approximately 3 to 5 hours long. It's important that you and your family are aware of the time frame of this surgery, because not knowing and having the patient in surgery for 3 hours and the family not realizing that this could be up to a 5-hour procedure can cause a great deal of anxiety. So it's important that you and your family know that the actual transplant surgery is 3 to 5 hours long. The surgeon will make an incision approximately 6 inches long, just above the groin. The artery and the vein of the new kidney will be attached to one of your arteries and veins. The new kidney's ureter, that is the tube which carries urine to the bladder, will be attached to your bladder, as seen in the picture. After the transplant itself, you will wake up in the transplant intensive care unit. You will have some mild discomfort, but you will be given medication to relieve your pain. In order to clear your lungs, the transplant staff will ask you to cough and deep breathe, and you may be given an incentive spirometer to help to clear the fluid from your lungs that collected during the actual surgery. Medications and fluid will be given to you through an IV for the first few days after your transplant, so you can expect that when you come out of surgery that you will have an IV. A catheter will also be placed to help you to pass urine. This is generally removed in about 5 days. Some patients will require dialysis for a short time if the kidney does not work right away. You will learn your medications and how to care for your transplant. The average length of hospitalization is approximately 6 to 7 days. After you leave the hospital, you will receive an appointment for your next visit in the transplant clinic and for the ureteral stent removal. During your actual transplant surgery, a stent is placed to keep the area open that attaches the ureter to the bladder. That is removed in the clinic under some local anesthesia, does not require you to be hospitalized, and is generally painless. We will follow you closely for the first few weeks. You should bring all medications and your transplant manual with you to all appointments. We will give you instructions for lab work and other tests that you might need. The purpose of these tests is to monitor your progress and to identify any complications as soon as possible. You will be seen in the clinic every week for the first month. It's important that you realize that up front so that you can make the appropriate arrangements for assistance with getting to the clinic, because as you probably know, transplant patients are not allowed to drive for the first 6 weeks after surgery. The visits will gradually decrease over the next few months. After 3 months, you may be returned to your regular doctor for follow-up care. Risks and complications. Such risks include, but are not limited to, bleeding that may occur during the surgery that require blood transfusions, Surgical complications such as urine leak, fluid collection, clotting of the kidney. There may be infection. There may be respiratory complications. There may be complications related to the post-transplant medications. There is a potential for transmittable diseases, and with all surgeries, there is the potential risk of death. Rejection. There is a chance that the transplanted kidney may not function well immediately or may not function at all, and function may be compromised due to the technical factors or other complications regarding the transplant surgery itself. At any time after transplant, but especially during the first 3 months, there is a risk for rejection and/or infection. Potential rejection. A tissue sample from the transplanted kidney, known as a biopsy, may be necessary to diagnose rejection or other complications that may adversely affect the transplanted kidney. If the patient experiences an episode of rejection, a daily visit to the clinic or rehospitalization may be necessary. Important that patients also are aware of the psychosocial risk of transplant. Those risks include the potential for poor outcomes, financial stressors, caregiver burnout or loss of support, guilt, resentment, altered body image, emotional and/or psychiatric disturbance, and altered mental status. Returning to work. Your health at the time of the transplant and the type of work that you do will be what determines how quickly you may return to work. Your transplant physician will let you know when you can resume your normal activities. For those of you that work out of the home, that includes your activities as well. If your daily activities included washing and cooking and mopping floors and emptying the dishwasher, those activities may need to be resumed on a part-time basis as well. You can't expect after a major surgery to immediately going back to everything you used to do. Most patients return to work on a part-time basis, then gradually work up to full-time work. Medications after your transplant. We've already stated that the body tries to get rid of anything that it considers foreign. After your transplant, your body will try to reject the transplanted kidney. In order to prevent rejection, we will give you immunosuppressive medications. These medications help the body to control the cells that will try to reject your new kidney. These medications lower your immune system. The immune system is the system in your body that helps you to fight infection. Therefore, you will be more susceptible to infection. We will also give you medications that help your body to fight those infections. Those medications include immunosuppression or anti-rejection medications. These are special medications that are designed to suppress or lower your immune system. Steroids. They are the first line of defense for rejection. Antibiotics. Antibiotics help your body prevent bacterial infection. Antivirals help your body fight viral infections. Antihypertension. These medications, although used to treat high blood pressure, will improve your blood flow to your new kidneys. Diuretics. These medications help to control the fluid in the body. They're known as water pills. You may be placed on vitamins or minerals. Because of all the other medications you're on, there is a good chance that you may also be placed on ulcer medications, as well as cholesterol-lowering agents. A successful transplant is directly related to you and your ability to take your medications correctly. You must take all of your medications exactly as they have been prescribed by your doctor. Each one of the medications help you to keep your new kidney healthy. If you stop taking your medications, you will reject your new kidney. Patients that do not take their medications correctly are generally not considered for other transplants if the kidney fails. Compliance is a major issue. Research. At the University Health Science Center and the University Transplant Center, our transplant team is actively involved with research into transplant techniques, new immunosuppressive medications, and due to our large number of patients and high success rate, we actively participate with ongoing research in the advancement of the transplant medications. After your transplant, one of our research nurses may contact you and ask if you are interested in participating in a voluntary study. It is a UNOS requirement that we report our activities and outcomes on an annual basis. For the most current outcome data, please refer to the website www.ustransplant.org. Now I'm going to provide you the secrets to getting your transplant sooner. There are 4 important things that you can do. Number 1, talk to your family, your friends, church members, work, employees about living donation. Because having a living donor could mean the difference between a 6-month and a 6-year wait for that kidney transplant. Always stay in touch with us. Make sure that we have current phone numbers, addresses, emergency contacts, so that we can reach you when it becomes your time for kidney transplant. Do not miss any scheduled appointments as part of your transplant evaluation. Really, seriously, please, don't miss any of your scheduled appointments. That's the key to getting you evaluated, listed, and transplanted. On behalf of the University Transplant Center, we are happy to answer any questions or concerns you may have regarding transplantation. Please feel free to contact our office during work hours. That's Monday through Friday, 8 a.m. to 5 p.m. We are closed on holidays. Our contact number is area code 210-567-5777 or toll-free 888-996-9633. After hours, please contact the hospital operator at area code 210-358-4000. Again, we wish you the best of health, and we look forward to working with you for your transplant needs.